Hello, everyone. This is Bill Riley, Director of the Office of Behavioral and Social Sciences Research. I wanted to thank you all for attending today's session. Our webinar today is titled Policy and Research Challenges in Advancing Care and Support for People with Mental Illnesses and Substance Use Disorders. Before I present our speakers, just a few housekeeping items. I'll remind you that you're all muted. And what we'll do is get your questions from the Q&A or chat section on the screen. So if you look kind of bottom right, you'll see a Q&A tab, and you can type in your questions there, and we'll take them there as well. I will note that from time to time, though, our muting system doesn't work perfectly, so I'd ask all of you who are on to mute your phones if you haven't already, so we don't get feedback and that sort of thing as we go forward. Let's see, what else? Today's webinar is going to be recorded and given after we get through all the things that are part of the 508 compliance. We'll have that posted, which is probably about a month from now. And I think that's all the housekeeping things that we have. I'm looking at my staff to make sure that's true. So it's my pleasure to introduce our speaker for the OBSSR Directors webinar today. It's Richard Frank. He's the Margaret T. Morris Professor of Health Economics in the Department of Healthcare Policy at Harvard Medical School. Dr. Frank previously served as the Deputy Assistant Secretary for Planning and Evaluation at Health and Human Services, directing their Office of Disability, Aging, and Long-Term Care Policy. He also served as a Special Advisor to the Office of the Secretary at DHHS, and also as Assistant Secretary for Planning and Evaluation in the Department of Health and Human Services. His research area is focused on economics of mental health and substance abuse care, long-term care financing policy, healthcare competition, implementation of health reform and disability policy. Dr. Frank has served as the editor of the Journal of Health Economics for over a decade, wrapping that up in 2014. He's had a number of awards, and I want to get to his presentation, so I won't list all of them, but I will note that he had the Taube Award from the American Public Health Association and the Emily Mumford Medal from Columbia University's Department of Psychiatry. He also received the John Eisenberg Mentorship Award from the National Research Services Awards and was elected to the Institute of Medicine in 1997. He's also the co-author with Sherry Glied of the book Better But Not Well. Dr. Frank, with that, I will turn it over to you, and thank you for your presentation today.
Sure. Thank you very much for having me, and I'm very pleased to be here. In my remarks today, I will probably wind up leaving you all with more questions than answers, but I guess that's akin to sort of saying more research is needed, which is always the right thing to say. If you look at this overview slide, my aim is really to discuss where we are and what I see as some of the upcoming research and policy challenges to the field. And I'm going to focus on three in particular. One is ensuring quality of care in systems that pay for value, that are sort of now becoming more and more prevalent in the healthcare system. Second, I'm going to talk about sort of the challenges that have been put on us by the successes at NIH of developing interventions for early interventions for serious mental illness and schizophrenia in particular. And then I'm going to talk about the role of mental illness and addictions in work and what we might be able to do about it, and then I'll just briefly wrap up. So let me start off by providing a little bit of context, which is that, over the last 10 years, we've made huge amounts of progress in expanding financial access to both mental health care and substance abuse treatment services. the Mental Health Parity and Addictions Equity Act, which passed in 2008, the Affordable Care Act, and then most recently the 21st Century Cures Act, have infused historically large amounts of resources into the treatment of these illnesses. And what we're starting to see is evidence of the impact of those efforts. And we can see that, we can begin to see that in the next slide that I'm about to show you. So here's a set of numbers that were taken from the National Health Interview Survey. And what I did is what we've done here is broken down the percentage of people sort of reporting that they were kept out of treatment for reasons of cost. And I've stratified, or the picture is stratified by income levels that correspond to the incomes associated with the Medicaid expansion and also the health insurance exchanges. And so that's on the exchanges are on the right and the Medicaid expansions on the left. And you can see in both cases, we've seen roughly a 30% decrease in the portion of people reporting that they can't get treatment due to a cost issue. On this next slide, this focuses more on substance use disorders. And this is from data from the state of Kentucky. And what you see is you see the population that was covered by the Medicaid expansion beginning in 2014 plotted against adults that were incumbent in the Medicaid program prior to that. Albeit they weren't a perfect comparison because there were some differences in terms of their characteristics for getting into the program. But what is notable is that you see a very steady climb in use of treatment services among the population that had their circumstances and their financing arrangements change compared to the population where there wasn't much change, which is the blue line. And so again, I think this furnishes rough evidence suggesting that when you expand coverage, when you pump more money into the system, people respond and they get more treatment. And so this is what I meant by my original assertion that we've done a lot recently to expand financial access. Now, what I'm really going to focus my remarks on are mostly sort of areas where there's been more limited progress, and I'm going to sort of talk a little bit about what we know about those areas, and then talk about what I think the challenges are going forward. And the three areas are how do we integrate mental health and substance use disorder care into the new forms of payment and delivery systems we're seeing, like accountable care organizations, integrated delivery systems, bundling projects, and the like. Things that are sort of more oriented towards population health and fixed, prospectively set budgets. The second area is a focus on duration of untreated psychosis and how do we get what we know about what to do early on in the course of psychosis, how do we get that implemented so that it has the maximum effect? And then third, what do we do about employment for people with mental illnesses and substance use disorders in a world where the underlying economy is changing fairly rapidly? Okay, so let me start by talking about how we're going to sort of work on trying to do a better job integrating mental health and substance use disorders care into payment systems and population-based delivery systems that have high-powered financial incentives. And what I mean by high-powered financial incentives means that the organizations carry financial risk and that they have incentives to try to do the same or more with less. And so that means there are incentives to do less. Now, what these systems all do is they consolidate funding across service lines. Episodes do it in the most narrow way, usually, for example, combining inpatient and post-acute care. Accountable care organizations essentially consolidate financing and organization across the entire continuum of care. And what all of these systems do is they move accountability towards a population focus. Now, under the right conditions, that can favor things like intervening early, prevention, and in some cases, really sort of focusing on meeting the needs of high-cost folks in a way that keeps them out of the hospital, keeps them out of the emergency room, so that you can provide quality care for less money. Now, the challenges to doing this, and it turns out that it is challenging to do this, is that the business case rely on savings after having met a quality threshold. And so that's what you need to do to be successful economically, which is you need to provide a certain level of quality, and if you've done that, then you're eligible to collect any savings that you might realize. Now, in the behavioral health area, quality measures tend to be underdeveloped, and therefore you see very few of them incorporated into the accountability systems used in these population-based payment arrangements. And so the risk here is that you could become eligible for collecting savings without necessarily doing a good job on the behavioral health side, because the measures don't really capture whether folks are doing a good job on a lot of dimensions. And so that is the risk, and in fact, in the studies that have been done so far, the evidence suggests that not much has changed for behavioral health under some of these new payment arrangements. So the consequences are, as I mentioned, we've changed the terms of coverage through expanded insurance, through infusion of new monies, but unless we get the accountability right alongside the new ways that we pay providers, we might wind up creating incentives to distort treatment or the supply of treatment in a way that will limit the ability to gain, to make gains in outcomes. And the evidence that I suggested from the sort of first generation of studies of, say, accountable care organizations tend to sort of be consistent with that. And so the things that are most worrisome is that the types of care that produce quality, particularly for the more complex conditions, and which are somewhat more costly to deliver, things like integration of behavioral health and medical care, and treating people with appropriate psychosocial care as a component of a larger package of supports. the quality of those tend not to be well measured compared to, say, the application of psychopharmacology. And so the danger is that we will develop accountability arrangements that will favor one type of treatment that may not get us to the improved outcomes for a broad range of patients that we might hope for. So the challenge or the research question is what do we measure and how? And I think what we need to do is, at the very least, we need to measure the quality of care so that if you do a good job on all the evidence-based treatments, applying them appropriately, integration, appropriate use of psychosocial services in particular, that's difficult to do. But it's important to find some measures where when you get a good quality score, you'll have done a good job or an appropriate job allocating the various types of treatment services to patients so as to produce outcomes. And so the challenge is to reward care that's likely to produce those good outcomes. And ideally, what we would do is we would just measure the outcomes. But we've learned painful lessons over time, which is that when we pay on outcomes, particularly in the behavioral health field, what happens is treatment providers have a strong incentive to make sure that they treat people who are going to get better. And we've had several studies done around the country at various times where either on the mental health or on the addiction side, we've paid on outcomes, and we've seen improved outcomes from the organizations that we paid, but almost all of it has been attributable to who was selected into treatment as opposed to the differences in treatment for a given population. So in the interim, I think what we're probably going to have to be satisfied with is a set of process measures that demonstrates what we know are productive approaches towards integration and deployment of psychosocial treatments based on clinical research to date. But at the end of the day, we need to move beyond that transition into things that are closer to outcomes. Now, all this needs to be done in the context of understanding that clinical organizations are suffering from measure overload. And so we have to be very, very strategic in what we choose to measure because there's only going to be a handful of measures allowed. And so there needs to be a lot of research and thinking about what set of measures are most likely to produce the broadest set of outcome improvements in the delivery of mental health and addiction services. Okay, let me shift now to duration of untreated psychosis or early intervention. Now, recent data from a number of small clinical studies and also the NIMH RAISE initiative show that treating psychoses early can affect the trajectory of illness. And that is very important, and it's based on a lot of advances in our understanding of the neuroscience behind these illnesses. Now, currently, or at least among people who eventually get treated, as reported in the RAISE study, the duration of untreated psychosis averages somewhere between 2.5 and 4 years. And I think everybody agrees that that's too long. Now, we know that mental disorders, in particular severe mental illnesses like psychoses, psychotic depression, and bipolar disorder contribute to a lot of both social and personal costs. For example, somewhere between 33 and 45% of Social Security disability insurance clients and Social Security supplemental security income recipients are disabled by mental illness. Then about 30% of women on TANF, which is a welfare program, have significant mental disorders, most often depression and trauma. And mental illness is just generally a major source of lost labor supply and productivity, as is addiction. So just to give you a flavor of the magnitude of what we're talking about, this is a picture of the trajectory of the number of people and the percentage of the SSI population that is disabled by a mental illness. And so you can see that in 2000, there's about 1.4 million people on SSI due to a mental illness. By 2010, there was 2.5 million, and that's continued to grow. And so now we're north of 42% of the supplemental security income population being there due to a mental illness. And this excludes intellectual disabilities. And so this is what we typically think, depression, bipolar, schizophrenia, eating disorders, and the like. So the NIMH has developed what I would say is a successful intervention, and it's really aimed at what do you do when you identify a person in the early, relatively early days of a psychotic episode. And the RAISE study, and I should probably tell you what RAISE stands for, which is Recovery After Initial Schizophrenia Episode. The RAISE study put together a package of services that included psychopharmacology, family psychoeducation, supported education and employment in order to keep people attached to sort of mainstream daily activities, and then individual resiliency training. And that package of services was really targeted at people who were identified early in their careers of schizophrenia. Here's a set of results from their report on the first 2 years. And those are quality of life scores on the vertical axis, and then duration of time, which you can see here is a 2-year follow-up. And what I want to direct your attention to is to compare the top red line with the triangles to the bottom red line with the circles. Those two are the intervention, the RAISE interventions for the intervention group, but they're targeted at different populations. One are people who have been, who are at least 74 weeks post their first episode, first psychotic break, and the others are less than that. And what is dramatic about this picture is how different the outcomes are in terms of the benefits of the intervention. So we know what to do. It gets people better, but it gets people quite a lot better. I don't know, my kids would say more better, if you intervene early in their careers versus later on. And I think this is an extraordinarily important finding. And the two bluish lines are the experiences of the control groups. Now, I'm an economist, so in a sense, the story is clear, and these are results by Bob Rosenthal and his colleagues that they reported out, and it basically monetizes the outcomes that I was just telling you about. And so, for example, the cost effectiveness when you intervene early is about $1,000 per quality of life unit, and compared to like 41,000. And so these are dramatic differences, and it just goes to show you how much more effective and cost-effective it is to intervene early. And I think, again, this is a story about targeting and getting people into treatment early. And it's an extraordinarily important lesson from this really massive clinical effort. These results, I think, pose for us the big research and policy challenge going forward. So what I want to argue is that the models are very well developed, in terms of knowing what to do once you've identified people and engaged them. However, the models for identifying and engaging people are much less well understood, and based on the strength of the RAISE study, people are implementing these RAISE-type interventions around the country in connection to the mental health block grants. And so we have opportunities to learn a tremendous amount about how communities respond to this new funding and use it to engage people in different ways. And there are models all around the country for doing this. And I think that the results highlight just how important it is for us, if we're going to make good use of the money, to figure out how to engage people early and then deliver the services that the RAISE program tested, so that we are likely to get cost-effective outcomes. Now, connected to that, so that means job one for research is to develop models for outreach and engagement. Job two is figuring out how to pay for things, because in fact, some of the services in the RAISE program are very much part of mainstream health insurance, but a lot of them aren't. And the question is, you need to find a way to pay for them, and you don't want to rely on Medicaid, because what you'd really like to be doing is intervening with people before they have fallen down to the extent that Medicaid will pick them up. And so we need to have some avenues, some strategies for paying for things efficiently and effectively in order to support outreach and engagement, but also to support scaling the full package of services. Okay, let me turn now to the third area, which is mental illness and work. And this is perhaps the most challenging of the three. Mental illness and substance use disorders both interfere with work functioning. This is reflected in a very large body of research showing that employment rates, hours worked if you are employed, and earnings if you work full-time are all affected by mental and addictive disorders. And the consequence of this is that there's extreme, well, maybe not extreme, but there's significant downward mobility among people that experience severe mental and substance use disorders. Now, it turns out work activities among people with these illnesses has been declining in recent years, even as access to treatment and quality of care has improved. And so just to give you an idea, today for most of the working age population with a severe mental disorder, they work at about just under 60% of the rate that an otherwise similar person would work. That is, somebody with similar demographic and background characteristics. For more moderate illnesses, it's somewhere in the sort of 10 to 20% region for reduced employment activity. So the challenge here is that the very deficits that are created by mental and substance use disorders are ones that play very badly in the economy. And so what you have on this graph is how the skills composition demanded by the labor market have been changing over time. And so if you look at those top two curves on the graph, the red one and the green one, you see that it's non-routine interpersonal skills and non-routine analytic skills that have really become more dominant in the labor market compared to, say, routine manual or non-routine manual or routine cognitive, which means that the economy is demanding that people be able to react quickly to changing environments with respect to either the delivery of services and the interpersonal requirements that demands, or reacting to changing circumstances or changing questions in an analytic way. And serious mental disorders and addictive disorders are exactly places where those deficits are most significant. And for that reason, not only do we need to have treatments that work as they traditionally have, but we need to think about what is it that we can do to best address the matching between sort of our clinical treatment and remedying or remediating the deficits that are keeping people out of the workforce. So, as I said, work is shifting, and it's shifting towards places where the impairments are the greatest. And I think what needs to happen here is that we need to develop our treatment and our delivery of treatment into interventions that will best remedy the demands for productivity in the modern labor market. And I think the consequences of doing so are very, very important because, in fact, one of the places that we've failed in our mental health and addiction delivery system is integrating folks with the severe versions of those illnesses into the mainstream of society. And I think work is a critical place where that happens, and it's a critical institution for aiding that to happen. And so for that reason, I think that we need to think about doubling down on sort of some of the interventions that have been being developed regarding cognitive remediation on the clinical side, but also creating workplaces and support systems and financing systems that go along with that can better support people where they're likely to be able to continue to be productive. So again, I think that there's a clinical research challenge here, which I mentioned, which is focus on cognitive functioning and cognitive remediation. I think we need to do things that promote employment of people with these impairments, from the impairments stemming from mental and addictive conditions. And then I think we need to start to better align and figuring out better ways to align the employer-individual and individual employment incentives to promote the early intervention and accommodation of people with serious illnesses. And there are sort of some small successes that have been experienced. The DMIE demonstration program intervened in workplaces early, kept people at work, and really experienced some successes on the mental health front in keeping people engaged with work, and as a result, keeping out of indicators of disability. So, as I started off with, I think there's been a great deal of progress made on expanding financial access. There's been improvement in our understanding of neuroscience related to these illnesses. What I think is we lag very much in our ability to deliver quality services or create incentives for quality services in our new delivery system. We haven't yet found the best ways to identify and engage people in the early stages of serious mental and addictive illnesses. And I think that poses both financing, ethical, and logistical challenges. And finally, I think we're failing to translate our learning into impacts on functioning so that we get fuller participation by people with serious disorders. So with that, I'll stop and take questions.
So Richard, thank you so much. That was great. So we're going to open this up for questions. And as I said before, those of you who are on the Q&A box in the bottom right, if you'll type in your questions there. I'm going to turn this over in a second to Bill Elwood, who coordinates our webinar series, to moderate the Q&A section with Dr. Frank. But I'm going to start us off, Richard, with a question as I was listening to your presentation. I'm going to see if I can tie together the three components of the presentation. So let me see if I don't make this too long. But there was some pretty compelling data that you showed on the almost a doubling of effect size from early intervention using the RAISE intervention aspects. And those data were looking awfully close to the levels of quality of life that you see in some normal populations. And then that healthcare cost, the cost of that intervention, which is so much less per unit of kind of quality of life improvement, is multiplied by the data that you showed on work and the sort of loss of economic productivity from lack of work in this population. And so I was thinking, going back to your first point about quality metrics and the need for those, if there's been any thought or any movement on the use of some quality metric like intervention within the first 12 months of a first psychotic break as an indicator of quality of care in this population.
I think that's that's a great question, and I think that's in a sense the logic of raised sort of takes you there in much the way you've just sort of set it out. Yeah, I think the tricky thing there is trying to hold people accountable for things that are not, where there isn't a clear path to their control. So for example, clinical programs as we've organized them and paid for them right now are really not in a great position to sort of figure out how to intervene early. And to some extent, at the end, I sort of alluded to sort of some ethical issues. And I think the logic of your question raises that very clearly, which is if you were to do that, you're demanding that clinical programs start getting involved in people's lives at times where we haven't traditionally done that, and potentially in ways that will make patients and their families really uncomfortable.
Yeah.
And so I think that the trick is we need to have those models about how we kind of reach out, touch, and engage these people before we can sort of hold folks accountable for that.
Okay, great, thank you. I'm going to turn this over to Bill Elwood to moderate. And again, if you have questions for Dr. Frank, if you'll type them in the Q&A box on the bottom right, we'll take those in order. Bill?
Thanks, Bill. Dr. Frank, we all know your expertise is in mental health and substance abuse issues in our own country, but a couple of questions have come in about how other countries, particularly those in Europe, like France, handle their mental health and substance abuse care, and if there's anything we might learn from their best practices to improve our own.
Yeah, well, I think I certainly think that there's always quite a bit to learn from other countries. One of the things that's interesting about the mental health area, it's a little different from the health area, is the United States is much less of an outlier in terms of the way it does things on the mental health side internationally than it is on the health side. So, for example, if you look at the way we spend money on health care, we're like, way above, anybody, the people that are in second and third place. I mean, we're just like, large percentages above them. In the mental health area, we're like right in the middle of the pack. If you think about the amount of money we spend in terms of our GDP, we're like at around 1% of GDP on behavioral health. And that's not that different from places like Germany and England and France and stuff like that. So I think that in terms of resources, and that sort of suggests, maybe there's a better analogy because what they do, they're doing with the same money we are. But for example, there are, I think, some pretty strong philosophical differences that we need to take account of. That is, some of these countries are much more institutionally oriented than we are. And I think, philosophically, at least for most of the last 40 years, we've been trying to really build or think about trying to build community-based systems. We haven't always been all that successful, but we've been pushing in that area. And, the British, I think, have a lot to teach us because they've done some really innovative things in those areas. Likewise, the Germans have done some innovative things, and I think those are worth looking carefully at. But I think that when you start having very institutionally oriented delivery systems, you sort of start to part company with at least the general philosophy in the U.S. between those countries and the U.S. anyway.
Thanks so much. That was really reassuring about our own system and an expert handling of a not exactly related question. So while we're on that topic, I'll skip over some of those earlier asked because it relates. Do you see any overlapping measures to include in either severely and persistently mentally ill people and or people with multiple diagnoses, chronic diagnoses, not necessarily mental illness, but perhaps HIV and depression, or rheumatoid arthritis and mental illness, and or substance abuse for that matter. How do you see them fitting into the system and providing quality care?
Yeah, I think that there's actually a great deal of potential to leverage things along those lines. So, for example, we know that people who take antipsychotic medications, such as those with bipolar disorder and schizophrenia, are at pretty high risk of diabetes. And so sort of having a measure that takes what we do on the diabetes front just for people who only have diabetes and using it as at least part of the measure for people with schizophrenia and looking at those separately will tell us something about how well they're integrating care. And so I think that's a very nice way to leverage the learning that we've done in sort of general chronic diseases to these populations. And likewise, on the substance use disorder front, I think there's integration issues there where where we can very much use the same general approaches that we use for measuring integration elsewhere for the addiction side.
Excellent. Thanks so much. Some of the physical diseases we just discussed, as well as mental illness and substance abuse, goes against the old-fashioned American values of self-reliance and toughing things out. And so there is a stigma associated with some of these issues. You spoke in your presentation about when it comes to measuring outcomes, providers purposely selecting patients who are prone to do well in care. Because of stigma, what issues do you see related to people with some of these mental illnesses and either not seeking care and therefore falling into Medicaid or being part of the underperforming before they fall out of the system?
Yeah, I think that's a great question. The argument that I was making during my talk was an economic argument. And in a sense, what you're layering on is, I think, saying, yeah, well, the economics cut against it, but it's even more so because of the stigma. So to the extent that, there's an economic disadvantage for taking on people with mental illnesses, if you don't have good quality measures that hold you accountable, that you won't necessarily invest in doing a great job. It's even that is aggravated by the fact that many clinicians and other patients are uncomfortable dealing with folks with serious mental illnesses. And I think that that is a serious problem, and it's something that, if we talk about something we can learn from other countries, the British have done some really important work on trying to address stigma, and they've actually rigorously evaluated it. And I think we have a lot to learn from them in terms of trying to promote measures that will attenuate that.
Great. You're following up on on natural experiments. What other ways do you suggest researchers approach behavioral health care?
Well, obviously, I think that the clinical work on randomized trials, I think, are good. I would like to really see sort of more work on sort of how do you really engage people in treatment early in their careers. And that's true of not only psychosis but also bipolar disorder. I think that's extraordinarily important, and I think just it raises many, many thorny issues that I've alluded to. So I think that's one thing, and I think some of that can be done experimentally, and some of it can be done through natural experiments. I think there are a lot of natural experiments underway because of the block grants set aside, but I actually think once we've learned something from that and narrowed the field and really want to figure out what we want to scale, doing some experiments would probably be advisable. I think that, I think the other one is the work functioning stuff, which there's some interesting work being done through NIMH on cognitive remediation. I think that, I don't understand all the clinical aspects of it, but what I do understand suggests that that should be, that's the sort of clinical path that I can see right now that will take us towards dealing with this changing work environment problem that I set out for you.
Nicely done, not just with that answer, but for the entire hour. I thank you so much for all the effort you put into creating this presentation and working with us back and forth before you ever dedicated this hour to us and the 100 people who joined us for your seminar. Those of you who asked to be unmuted or whose questions we couldn't get to completely, I apologize. If you do email them to me on this last slide, I will be happy to follow up directly. Once we download the recording of this seminar and caption Dr. Frank's words, we will make it available through our website. We will tweet about it and make that available to you. Next month's director's seminar is Dr. Jim Spilsbury from Case Western Reserve. On 18 April, he will discuss using smartphone and motion sensor technology to study 11 and 12-year-old sleep. And on Tuesday, April 25th, is OBSSR's 10th annual Matilda White Riley Behavior and Social Sciences Honors. That is a live event that we will make available later in videocast. Our distinguished scholar this year is Mark Hayward from the University of Texas, and our early stage investigator winners are Erica Fuchs from UTMB, Emily Holman from Penn State, Frank Inferno from Arizona State, and Jacqueline Torres from UCSF. Dr. Frank, thank you again so very much, and thank all of you for joining us.
It was my pleasure. Thank you.
Thanks all.